By Dr. Priyadarshini Kulkarni and Dr. Gauriya. So today's session will be moderated by Dr. Priyadarshini. I wish to introduce Dr. Priyadarshini to all. She serves as a consultant in palliative medicine in Pune, a founder of Support India, an Indian champion for Elizabeth Kubler-Ross Foundation, served as a medical director for Cipla Palliative Care, and a well-renowned writer too. Welcome, Dr. Priyadarshini, and it's over to you.
Okay, thanks a lot, Raj Lakshmi. Uh, a very welcome to all of you. I think we are already little late, so I'll just uh, do a brief job of introducing Dr. Raj Gopal and Dr. Punita. I think Dr. Raj Gopal needs no introduction to this group, but still, as a formal introduction, Sir is a director of WHO Collaborating Center at Trivandrum and the founder chairman of Pallium India. His initiatives to remove regulatory barriers in availability of oral morphine for pain relief have contributed to simplification of narcotic regulations in 17 of 29 states of India and more, and I think the exact number we don't know, to the amendment of NDPS Act of India. His initiative has also contributed to the development of a government policy on palliative care in the state of Kerala in 2008 and Government of India's National Palliative Care Strategy in 2012. The international organization Human Rights Watch honored Sir with Alison Des Forges Award at Los Angeles in November 2014. In 2017, a documentary film titled Hippocratic 18 Experiments in Gently Shaking the World, based on Sir's contribution to palliative care, was released by Moonshine Agency Australia. He was named one of the 30 most influential leaders in hospice and palliative medicine by American Academy of Hospice and Palliative Medicine in 2017. In 2018, Dr. Rajgopal was honored with Padma Shri, the third highest civilian award given annually from Republic of India. I think more than all this introductory things, I think he is a wonderful teacher and a wonderful human being who keeps inspiring all of us, generations after generations, I should say, to do more and more into palliative care. Our second speaker today is Dr. Punita Sharma. Welcome, Dr. Punita. She currently practices palliative care in New Jersey, USA. She is a board certified in internal medicine and hospice and palliative care. She is extremely passionate about increasing awareness and education about palliative care. She has trained numerous residents and fellows in her role as a fellowship director for hospice and palliative care. She is a New Jersey Health Executive Leadership Fellow on improving end of life care. Most recently, she has been invited to serve on New Jersey Hospital Association's practitioner orders for life sustaining treatment work group to improve end of life care for the state. Passionate about reframing the experience of healthcare from both consumer and provider perspective, she is currently pursuing Masters in Healthcare Management at Harvard T.H. Chan School of Public Health. I welcome both Sir and Dr. Panita to start today's session, Palliative Care Current Status. I think Raj Lakshmi, we are at 7:20, so we should be going on till 7:50.
Yes, Doctor.
Yeah.
Since it's interactive.
Okay, so, yeah, sir, over to you and Dr. Punita, please.
Hi, good morning from United States and good evening from India. I am extremely thrilled to be a part of this faculty and to be presenting to such a varied and learned group of individuals. Rajalakshmi, I'm unable to share my screen because it says host disable the screen. So can you give me the screening rights?
Can you try now?
Let me try again. Okay. Are you able to see my screen now?
Yes, ma'am.
Are you able to see the complete screen?
Yes, yes.
All right. So without any further delay, I think let's jump into the presentation. So our goals for today are: we're going to be defining palliative care as prevention and treatment of health-related suffering. We'll try to understand the differences between hospice and palliative care. We'll understand the current need access gap. We will list the interventions undertaken with palliative care and identify some of the barriers and stages of development of PAL care delivery in India, and also look at some of the recent developments in palliative care policy in India. All right, so what do patients with serious illnesses want? They want their symptoms to be controlled. They want to remain in control when their functional capacity is declining. They want to relieve burden on their loved ones. They want to avoid prolonging the dying process, and they want to strengthen the relationships with their loved ones. But what actually happens? Unfortunately, across the world, uh, and maybe some countries better than others, the last phase of the serious illness prior to death is characterized by fragmented care, inadequate treatment of distressing symptoms, multiple transitions amongst care settings, and increasing amounts of responsibilities without understanding or training for families and caregivers. Time that should have been spent in doing what matters to those individuals who are suffering with serious illnesses and taking care of any unfinished business that they may have is often turned into a series of medical events. India ranks at the bottom of quality of death index in overall score. There's a clear disconnect here, folks. We got to do better. We can do better. So what if, let's reframe this problem. What if patients were asked what matters to them? What if skillful communication happened in a timely manner? What if everybody was brought onto the same page as far as the trajectory of the illness and the expectations and the anticipations were all clarified? What if we were making sure that our patients' symptoms were adequately treated? What if support was provided to the patients and the caregivers throughout the trajectory of an individual's illness? What if goal concordant care could be provided? What if we could tell the patients and families and caregivers how to manage crisis? This could totally look different. I think, as Dame Cicely Saunders has pointed out, who's one of the pioneers of the modern hospice and pal care movement, this can be done in a much better way. She clearly said it many, many decades ago. We will do all we can, not only to help you die peacefully, but also to live until you die. So, coming to the definition of palliative care, death is not strictly a medical event. Ideally, healthcare for those nearing the end of life should harmonize with social, psychological, and spiritual support. All people with serious illnesses, advanced illnesses, who may be approaching the end of life are entitled to high quality, compassionate, evidence based care, which is consistent with their wishes. And this is what palliative care is about. WHO defines this very, very clearly. It's an approach. Palliative care is an approach that improves the quality of life of patients and their families who are facing the problems associated with a life limiting or a life threatening illness through the prevention and relief of suffering. And I want to stress the word prevention and relief of suffering by means of early identification and treatment of symptoms, whether they are physical symptoms, whether they are psychosocial concerns or spiritual concerns.
हो हो तिने आता मला
So
कॉल केला म्हणजे अजून येईल मग बबलूचं एंडोस्कोपी करून पुन्हा
I would
Gauriya,
I
will
would
you mute
request
your
everybody
microphone?
to please put yourselves on mute. Thank you. All right, so I wanted to stress here that palliative care helps prevention as well as management of health-related suffering, and that's the goal. So what are some of the worldwide facts? How are we doing? 61 million people, folks, are in need of palliative care. 78% of them, they live in low and middle income countries. The global need is only going to increase with aging population. The incidence of chronic diseases rises with aging. We yet do not have enough people to be able to provide palliative care. We all got to do better. We all got to do better. What are some of the current advancements? And I think I'm standing or presenting in front of the couple of pioneers who have taken this to a completely different level. Kerala, incorporation of palliative care in statewide healthcare policy, which has about like 3% of the Indian population, totally stands out. Creation of a national program for palliative care, amendment of the Narcotic Drugs and Psychotropic Substances Act, inclusion of palliative care in undergraduate medical education from 2019, and inclusion of palliative care in national health policy. These are all steps towards the right direction. So what are some of the current models of palliative care? As in any medical discipline, I think some core elements of palliative care, such as aligning treatment with the patient's goals and basic symptom management, should be routine aspects of care, which should be delivered by any practitioner, a concept which is termed as generalist level palliative care. And the link to the article, which clearly defines it as to what are the responsibilities of a generalist palliative care provider versus a specialist palliative care provider, are there in the link. The vice versa is also true, that any palliative care physician should be able to provide primary care as well. I think it's imperative, especially where there is a big gap where medical services are not available to the extent that we want them to be. It's imperative that palliative care folks will have to take on some responsibilities of providing care as a palliative care as a primary care physician. Other skills which are more complex and take years of training to learn, such as negotiating very difficult family meetings, addressing veiled existential distress, or managing refractory symptoms, this can be undertaken by the palliative care specialist. A concept which is, in easier terms, if it's easier to understand, let's say if you have a case of hypertension or a coronary artery disease, some amount of intervention is done by a primary care provider. But when it gets complicated, when you have, let's say, hypertension related to renal artery stenosis, or you have coronary artery disease which needs intervention, you refer them to a specialist. But some amount of basic care can be done by a primary care. So hence, those same principles can be utilized as far as palliative care is concerned. It is imperative that primary care physicians start incorporating palliative care principles into their day-to-day practice, and vice versa, that palliative care folks also be able to provide primary care to patients and individuals suffering with life-limiting and serious illnesses. So conditions which are requiring palliative care, I think you all know. But what I want to point out here is that humanitarian emergencies and crises, such as the COVID-19 pandemic, which caused massive loss of life, disruption of livelihoods, breakdown of society, prevention and relief of suffering in those cases should be made accessible for anyone suffering physically, psychologically, socially, and spiritually, and not only for those who are with life-limiting conditions. There is also an ethical imperative to be providing palliative care and symptom control for expectant patients based on the medical and ethical principles of beneficence and non-abandonment. Failure to provide these highly vulnerable patients by treating aggressively and immediately any physical and psychological suffering, that constitutes abandonment, and it's ethically absolutely unacceptable. Hoping that everyone is awake at this point in time, there are some true and false simple questions that I would like you to consider. So let's start off with the first one. And Rajalakshmi, are you able to get us to a poll? Excellent. All right. So palliative care uses a team approach. Yes or no? True or false?
Has everybody been told what to do, how to vote?
Yes, sir. All are doing
Okay.
All right. Excellent. So we got palliative care uses a team approach. That's correct. Palliative care is synonymous with terminal care. That's false. Palliative care includes family in the care process. That's true. Palliative care focuses on the whole person. Correct. And palliative care cannot be practiced in conjunction with other therapies. Let's see, I'm scrolling my screen down. So somebody said true, and majority of the folks said false. Palliative care cannot be practiced in conjunction with other therapies. We will come back to this point, and I will show you what's the current model of palliative care delivery. Okay, so coming to the first question, who can provide palliative care? I mean, it's a multidisciplinary team involving physicians, nurses, support workers, paramedics, pharmacists, physiotherapists. I also want to point out here that volunteers and community are playing an increasing role in helping support patients and their families by providing physical help, psychological help, and sometimes being the only support. Especially, I mean, look at Kerala, look at Canada, look at US, you look at UK, look at Australia. All of these places, you can see an increasing amount of effort by the community to help support these patients. What are some of the goals of palliative care? Improving care, making sure that as a result of improving individual care, population health improves. You improve value by guiding the patients and families in defining goals of care and having early conversations. And you improve caregiver health by decreasing burnout, ensuring that everybody knows what to expect and how to manage those crises. All right, so the next question. I think that tags on to the last question from the previous question. Choose the most appropriate answer from the options given below. When should palliative care begin? And you can choose either A, B, C, or D. From the time of diagnosis of a chronic illness. Correct. That's the correct answer. All right. So bringing you to the concept of when palliative care should be delivered. So if you look at this slide, the ideal time of providing palliative care is at the time of presentation or diagnosis of a serious illness. As the trajectory of an individual's illness moves along, the amount of curative or restorative therapy continues to decrease. So if you look at the upper triangle, the curative and the restorative therapy interventions, they are continuing to decrease, whereas at the same time, palliative care interventions continue to increase. When the expected life expectancy is about 6 months or less, that's when the concept of hospice care comes in. And post-death is followed by bereavement support for the caregivers. So the optimal time of referral to palliative care is at the time of diagnosis or presentation. Palliative care can be concurrently provided while an individual is going curative or restorative therapy. And that's the demarcation between palliative therapy as well as hospice. And we will come back to that concept. So what are some of the palliative care domains? The domains are a framework for clinical practice guidelines for quality palliative care. It involves structure and processes of care. For example, an interdisciplinary team provides an assessment based on the patient and family's goals of care, prognosis, disposition where the patients are going to be living, physical aspect of care, making sure that their symptoms are adequately managed, psychological aspects of care, making sure anxiety, depression, delirium, cognitive impairment, stress, anything like that, all of those symptoms are taken care of. Looking at social aspects of care, family, friend, caregiver, interaction support, and management of crises. Looking at spiritual aspects of care, any kind of like spiritual, religious, or existential crises. What are their hopes? What are their fears? Anything related to forgiveness that needs to happen. Looking at cultural aspects of care. Are there any language barriers? Are there any rituals that an individual or family follows? Are there any dietary restrictions? And then, of course, care of the imminently dying, presence of being present, recognizing the symptoms as to when an individual is in the last phase of their life, and ensuring that appropriate communication happens with the patient and family, and normalization of the dying process. Death is very much a part of life. Making sure that we communicate the prognosis in terms of like hours, days, weeks to the patients and families, and looking at some of the ethical and legal aspects of care. Who's the decision maker? If in case the individual is not able to speak for themselves, are there any advance directives? So, difference between palliative care and hospice. Hospice is that part of palliative care which is for individuals who have a limited life expectancy of 6 months or less. The difference between the two is the intent. Palliative care can be provided concurrently at the time of diagnosis of a life limiting, life threatening illness. Curative interventions can continue to occur while palliative care is being provided, whereas once somebody is under hospice care, this is a concept, yes, which is present more in the Western world and partly related to the pairs. Hospice is when all the restorative or curative therapy has been forgiven and there is no longer a desire to continue any of the curative or restorative treatments. So that's the difference between palliative care and hospice. The interventions, curative interventions, are not further taken under hospice. Yes, physical symptoms, symptom management, provision of comfort, those treatments continue. So the principles remain the same, but it's the intent as far as the curative or restorative treatments are concerned is different. So what's the secret sauce of palliative care? The secret sauce of palliative care is timely, skillful communication, symptom management, coordinated care, making sure everybody knows what is the plan with the patient. There's a lot of specialists that may be involved in an individual's care, from an oncologist to a lung specialist to a social worker to physical therapist, ensuring that there is a personalized care plan that is developed for each and every single patient. That's the essence. That's the secret sauce. What are some of the barriers to palliative care? Policy, education, medications are still not available. There are beliefs about, death and dying. Often death is not considered as a part of life, and there are misconceptions about palliative care, that it is only for patients who are with cancer or for the last weeks of life. Categorization of palliative care development. So WHO defines, various categories between 1 to 4. Category 1 means that there are no palliative care interventions that are available in a country. 2 means the capacity is building up. 3A means there are some isolated palliative care programs. 3B means generalized palliative care is available. 4A is palliative care is at a preliminary stage of integration. And 4B is palliative care is an advanced stage of integration with the general health policy of the countries. So India stands at 3A as per WHO guidelines. Telemedicine. I don't know about how much of telemedicine was undertaken uh, during the pandemic, during the ongoing pandemic in India, and would love to, hear your experiences once we get to the case presentation towards the last. But I can tell you here in the US, we used telemedicine like no tomorrow. I mean, when families were not able to come to the hospital and there were patients who were admitted to the hospital, it helped us connect the patients with their families. And actually, this pandemic taught us that we could still function during this time of adversity and that human connection could still be maintained. I mean, we took our, iPads into the patient's rooms, all gowned up, using so many of the purple wipes, and Anne must be, familiar with it. The purple wipes are the bleach wipes, with which we were cleaning our tablets and iPads and taking into the patient's rooms and ensuring that we would communicate both with the patients as well as the families and help them connect with each other. So, telemedicine was a great way of helping us maintain that connection. So what are some of the interventions that countries can do? And I would pass on the baton to Dr. Rajagopal.
Dr. Raj, you're muted.
As usual. Thanks, Raju. Punita, what a great start. That was absolutely, absolutely clear. And I hope the participants are not feeling a bit irritated with us for going to the basics. This was deliberate. There would be a lot of misconceptions. even among people who have undergone training. And particularly some points that Punita highlighted were absolutely important, like the concept of serious health-related suffering, and how I would like to highlight that point because we are in this country. Primary care is very variable in various parts of the country. We have people here sitting in Trivandrum or Madhya Pradesh which have a bit better healthcare than the rest of the country. And there are people from some other states where healthcare itself is very basic. So we go there and find primary health care, the lack of primary health care causing numerous problems. And I remember a nurse from Uganda once saying, I don't care about your definitions. If I go for palliative home care and find that a woman is in obstructed labor, I will help her. And that is the spirit of caring. That's the spirit of relief of suffering. So, depending on that, we keep having to adapt. We take on care of people with paraplegia. We take on care of people with sometimes with acute problems, post-operative pains, so many things. So, where there is serious health-related suffering, we step in. I will take only about 6 minutes to point out some important developments in recent years, especially those who were trained many years back may not be aware of them. And some of those things are very recent. I do not mean the art and science of palliative medicine. I mean specifically about matters related to policy. Uh, Raju, I need to share a screen. Thank you.
So you can do it now.
Thank you. So, about the recent positive developments that I wanted to talk about, the first one, this I think practically everyone would know that the Narcotic Drugs and Psychotropic Substances Act was amended in 2014, where prior to that, every institution needed 3 to sometimes even 5 licenses, all to be given by different agencies, and all would usually have validity expiring in a matter of about 3 months, so that it was almost impossible to have concurrent access to all the licenses. That was terrible. And the law was changed by the Indian Parliament in 2014, which means that now all the states have the same rules. The new law created a class of medicines called essential narcotic drugs, and the medicines that we use. Do you know which medicines come under ENDs? Essential narcotic drugs. Among those we use morphine, fentanyl, and methadone. We'll in the course of in this refresher course, there will be discussion about methadone more, and that is something I hope everyone will learn to use with confidence, and will be trying to access it at the end of the course. So now, once you have the approval as a recognized medical institution from your state drug controller, you do not need any of these licenses. That is the law. The law, like in most low and middle income countries, very often have huge implementation gaps. So in many states, implementation is very incomplete. And recently, I see that there is somebody from Uttarakhand. There was quite a significant effort in Uttarakhand, but we persisted, and the new rules were made applicable. So anybody who finds that in your own state the law change is not applicable, they are still asking for all sorts of licenses, or the drug controller is not giving out the status of RMI, please contact us. We will work together. Just learning a bit of science is simply not enough. As Atul Gawande reminds us, we are not only doctors, we are also human beings. We are also citizens. He talks about the citizen doctor. Our job is not to write a prescription. Our job is to make sure that the patient also has access to that medicine so that they can get pain relief. Let us work together on this. Of course, I hope all of you know already that from 2019 batch of MBBS students, they have all this in their curriculum. It is not one module called palliative care. Palliative care is mentioned, pain management comes in, end of life care comes in, and there is an 8-com module, attitude, ethics, and communication. Between them, most will be taken care of, except possibly symptoms other than pain. We are working towards including that in end of life care so that they all will learn it. There will be an implementation gap, and all of us must try to work at it. Unfortunately, the formation of the National Medical Commission caused some more problems in implementation, which is eventually good, I hope. But for the time being, you should know that every university, every medical council rules permit medical colleges to engage adjunct faculty. If they want, any medical college can invite you as a faculty to teach these aspects of medical education. This is another thing in which I hope, even after the fresher course, we will continue to interact. This is something that we want to facilitate. And an exciting development, the new National Health Policy of 2017 includes palliative care. Current program is inclusion in primary health care. This is not just vision. By 31st March 2021, sorry for the spelling, it's a typo. National level trainers and state level trainers have already been trained in palliative care. It's basic training. Essentially, within the next 2 months, healthcare workers from the doctor, nurse, multipurpose worker, and ASHA worker all would have had an exposure to palliative care, reaching 150,000 health and wellness centers. At the very least, very least, it will increase awareness. It will make people reach out to others when they need help. But hopefully, we will be able to give in the next couple of years some kind of palliative care through the 150,000 health and wellness centers. This, as you can see, ladies and gentlemen, the three things really form the WHO triangle. The law has been changed. Undergraduate education includes palliative care, and the national health policy, which is being implemented, includes palliative care. It is such a tremendous thing. But Punita says only 1% of Indians still receive palliative care, and Punita is right. Or maybe we can argue about the percentage. Okay, if you claim it is 1.9, we will not fight. But whatever that is, let us hope that we are on a steep part of the curve. These three achievements have been there. So the time is right for a tremendous increase in palliative care access. At least let us hope that when we did a previous refresher course a few years back, a nurse from Northern Kerala came and a bit angrily said, he was saying, when I started palliative care 15 years back, you told us that only 1% of the Indians have palliative care. Now you say the same thing. What's happening here? And he was right. But now we hope really things are changing. Ladies and gentlemen, this is a mission. which we have worked at for a quarter of a century or more. And now we are ready to start flying. And this means all of us being citizen doctors, as Atul Gawande said, and working towards practical application of these three sides of the triangle. Uh, I will nevertheless point out that there is a huge gap. Nevertheless, the current program does not include inclusion of palliative care in medical colleges and other tertiary care centers. That will be a huge gap. Medical students learn it, but they don't see it being practiced. The National Program for Palliative Care, which was formed in 2012, does include provision for this, which has not been implemented. This is another thing for us to work on. So these were the learning objectives that Punita started with. Defining palliative care as prevention and treatment of serious health-related suffering. Understanding that palliative care begins when suffering starts and does not end with the death of the patient, but continues as bereavement support. And that hospice, if the term is used as a building, it is for end-of-life care. If the term is used as a concept, especially outside of USA, it becomes synonymous with palliative care. We talked a lot about the huge gap. 98 or 99% people still not getting palliative care. Punita highlighted the kinds of interventions which in this context, this Indian context, so social interventions will be so much more, like giving them food when they are starving, even that. And Punita identified the major barriers, and we talked about the, especially with the policy changes, the changes development and current status of the policy. Thank you very much.
Thanks a lot, Dr. Punita and Rajgopal sir, for this enlightening first lecture of the series. Rajalakshmi, should we, how are we doing with the time today? Should we be taking discussion right now or after the case presentation?
I think we have another 7 minutes for discussion.
Okay.
Dr. Punita was showing a slide. Dr. Punita, you wish to speak something? Dr. Punita, you're muted.
Are you able to hear me now?
Yes, yes.
Yes.
Yeah, so I just wanted to, just mention one thing. As Dr. Rajagopal said, you are at the inflection point now. The energy has been building up. You can take it to the next level. And wanted to share this quote by Atul Gawande, which he has mentioned in his book called Being Mortal. And, I read this book and it is just amazing. It gives you the overall, picture and the overall concept and just forces you to think, what are we doing? We deal with individuals as organ systems. We deal with individuals as skills. I'm I'm a specialist in this discipline or I'm a specialist in that discipline. But have we lost that concept of providing total care, right? A total human-based care. So our ultimate goal, after all, is not a good death, but a good life to the very end. And we cannot lose sight of this goal. So just wanted to, mention this.
Hello. At this point, are there any questions or comments from the participants?
You can either unmute yourself and speak or give your suggestions or comments in the chat too.
Yeah, I just wanted to ask Dr. Punita one thing. She had mentioned that the difference between palliative care and hospice is the curative part of it. But I thought in palliative care also we don't concentrate on the curative part of it.
So if you look at the model of palliative care delivery, that's the entire essence, that you want to integrate palliative care into mainstream treatments for patients who are suffering with serious illnesses. And hospice care comes in when the intent is no longer for continuing curative or restorative treatments, when the focus solely becomes, comfort and symptom management. And you're no longer, for example, pursuing any, chemotherapy, or you're not pursuing left ventricular assist devices for advanced congestive heart failure or heart transplants and things like that. So yes, in the United States, there is a differentiation between palliative care and hospice, but outside where this concept, is synonymous, as Dr. Rajagopal already pointed out, hospice is a part of palliative care. It's a certain set of interventions for end of life care when the life expectancy is 6 months or less. Palliative care can be provided at any age and at any stage. Hospice is for patients who are expected to live for 6 months or less.
Any other questions?
I would like to know, can you hear me?
Mm-hmm.
I would like to ask Dr. Rajagopal about the present curriculum, UG curriculum, where palliative care was introduced in 2019. Does it have a concept about good death, that no unnecessary intervention to prolong life, which
Yes,
may cause
Dr.
suffering to the patient?
Yes, Dr. Elizabeth. End of life care is clearly a module. And so yes, the one word answer is yes. There is a problem, nevertheless, Dr. Elizabeth. Why we all have to facilitate this is, who is going to teach this? Out of 541 medical colleges in the country, only about 40 have any palliative care. 500 do not. So the faculty who teach this would end up teaching the age-old things, which is what we are trying to change. So what we are doing currently is, the module preparation is underway, and we, in the month of July, we are hoping to do training the trainers program for the faculty of medical colleges. Understandably, it will take some time. Everybody will not come, but at least 100 medical colleges we are trying to reach in the year. So the one word answer was yes, but the more complicated answer is, it will take some time before what should be taught is taught. Thank you, Dr. Elizabeth.
Thank you.
So just to add on to Dr. Rajagopal's discussion, we here at the United States also started on a similar pathway. So initially, palliative care was not recognized as a formal board, according to the American Board of Medical Specialties or American Board of Internal Medicine. So initially, folks could work, and they had a certain set of requirements to be completed before they could actually sit for the board exam without having undergone a formal fellowship. So 2012 was the time when you could grandfather into the field of palliative care. And following 2012, you had to do a formal fellowship through any of the residency programs and fellowship programs that exist throughout the country. And that gave time for folks to develop those programs. So in 2012, the division or the discipline of hospice and palliative care was introduced as a formal board and formal specialty.
Any other comments? Or we should just go to case presentation, Raj Lakshmi. It's 8 o'clock now.
Yes, ma'am, we can move on to case presentation because we do have a very detailed case presentation today.
Okay. So, should I request Dr. Sangamitra for case presentation?
Yes. Can I share my
Hi.
screen? Hi. Hi, ma'am.
Hi.
I'm just not wasting out any more time. Try to share my screen. Is it okay for everyone?
Yes, ma'am, we can see your presentation. You can start your presentation.
Okay. So, just at the beginning of this presentation, I would like to put on a disclaimer that I've used few pictures of the real patient that I'm presenting the case on. And I have properly taken permission from the immediate family member for using the same. My patient was a 46-year-old male who suffered from advanced squamous cell carcinoma of the alveolus. A background of his is that he belongs to a joint family and he has been a financially well-off person. He has two children, 9-year-old daughter and a 5-year-old son. His wife is a homemaker and he runs his own printing business, which is part of his family business. So if you can see this ghastly picture of this patient, you can actually imagine what his condition was when he first came to us. He had severe pain, a foul smelling wound on the right side of the cheek, multiple fistulae on the same, and that extended from the right temple to the lower neck. There was continuous discharge from this wound, and he had a Ryle's tube in place, which had been there since a long time. Also complained of constipation. So these were the main presenting complaints when we first got to see this patient. Just to give you a small history about how it started, he noticed a small pinhead-sized nodule above his right upper molar tooth, exactly 24 months back. And, just thinking it to be something else, he just went on for some Ayurvedic medications on and off for around 4 months, and just before having some kind of pain and bleeding from that particular area. So he consulted a dental surgeon in his locality. Thankfully, the surgeon did advise him a biopsy, and then he was diagnosed of a squamous cell carcinoma. And that was in April 2019. Immediately, they decided to take him to New Delhi, and they consulted a cancer center, a private cancer center there, and underwent surgery and chemoradiation. But then it recurred after another 8 months again, and then they had, as they gave me the history, they didn't have any faith in the New Delhi hospital, so they went to Mumbai this time. And here, the Mumbai doctors attempted a reconstruction surgery, which actually failed. They came back home with some kind of unmanaged pain, an open wound, a disfigured face, and he was at home for another 7 to 8 months, during which his condition really deteriorated. And they again decided to go to another hospital in Bangalore, where they were advised palliative care. So within this period of starting with a nodule in the upper molar tooth and coming through all this journey of surgery, chemo, radiation, Ayurvedic therapy and whatnot, they were advised palliative care only very recently. But interestingly, they didn't actually, consult any palliative care doctor as advised by that hospital. And they landed up in this particular period of lockdown, and almost for 7 months, they again continued with the Ayurvedic treatment. Perhaps because of the symptoms that were deteriorating and because of the intense pain that he was suffering from, they found out my contact and they contacted me only in November 2020. And the patient passed away in February 21. For examination, during his presentation, the extension, as I had already told you, it was, and you can see, if you remember the picture, it is right from the right temple to the supraclavicular line, and then, covering the whole part of the preauricular area to the side of the upper lip horizontally. His right eye was also involved. And a lot of unevenly distributed multiple ulcerated, non-ulcerated sarcomatoid ulcers, nodular lesions were seen. A lot of fistulous lesions were also there. There were areas of mixed hemorrhagic lesions, and there were also some bleeders, some active bleeders. At least those things when dressed were, they bled on touch. The upper jaw and the lower jaw of the right side were all exposed, and we could actually see the lateral border of the tongue. There was a continuous foul-smelling mixed hemorrhagic and yellowish discharge from the exposed area, and you could also see a Ryle's tube. So this was a picture that anybody can imagine without even looking at a real patient. So the poor general condition was actually a matter of concern for this patient. He had a swollen and edematous face and part of the neck also. He was not really having anything, anything special regarding his nutrition. So that led to a lot of pallor and dehydration, and many other laboratory markers were deranged. A low BP and a low volume pulse can be, we can actually expect that. Systemically, not much, but then yes, he had a very dry abdominal skin. There was muscle wasting in both upper and lower limbs with near normal joint motility perhaps. When we started inquiring and evaluating the pain, it was 10 in 10 in NRS, and it was not at all relieved by anything, anything that he was taking. It was continuous, and we thought that, it is a soft tissue pain with a lot of burning sensation on and off. So radiating to the occipital area of the head and also the right upper back of the shoulder. So it was a mixed nociceptive and neuropathic pain that he was going through. So we ordered some very basic routine examinations, but the family and the patient himself wanted to have a CT scan of the head and neck area just to see where it has progressed. In the later slides, you'll definitely come to know why perhaps they had ordered a CT of the head and neck area. We treated him according to his presenting symptoms only. The pain, the wound and exuded, the malodor, other symptoms, taking care of his feeding tube, trying to mobilize him when he was in the hospital. And, and we were successful in, taking care of the pain with at least 10 milligrams of morphine, oral morphine Q4H and SOS. We also, started him on some IV fluids for dehydration, and the Ryle's tube was not in a position to be changed at all. So we started flushing on with some soda bicarb and other fluids. The main concerns that I felt was a challenge for the team and for myself was that the innumerous number of psychosocial aspects that he had. He was in complete denial, and the discussions always involved his willingness, his wanting to, his urge to get well soon. He used to tell us that I will actually get well very soon. And something like, I have been discussing this with my brother who stays in the US, and he's taking this discussion forward with another doctor who's another specialist there, and he's a big specialist. And, I have a lot of hope on this doctor. And there are, a few people who have been cured with Ayurveda, and you just need to control my pain. He actually directed me to do that. And then he was concerned about his disfigurement. He always told us that I wanted to be an actor in my life. So I was the most handsome person in my whole family. So look what has happened to me because of this disease. But I know that once I get well, I will go for a plastic surgery and I can regain my, my handsome face once again. He did have, he did have a lot of concern for the family. His children were quite close to him. So he always told us that, my daughter is weak in maths and I used to teach her regularly. So what she might be doing. These concerns were always in his mind. And whenever we had a discussion, whenever we talked about his family, about his concerns, we tried exploring, he was always talking about his children. He was totally angry with God. And whatever he said was that, I am a non-vegetarian. I have been doing regular puja all my life, and I don't know why God is doing this to me. This is purely injustice in his part, and I really don't deserve this suffering. So his main concern was always pain and disfigurement. Having said this also, he used to give us the solution that you are managing my pain. I feel my pain is gone. And once I get well, I will go for a plastic surgery and I will get rid of this disfigurement also. So in summary, you can see in this picture, he's with his wife. He was actually a handsome young man. He was in denial for the incurability of his disease till the day of his death. He was completely pain-free till the end. But I strongly feel that an earlier referral would have given us some more time to manage his symptoms, to manage his especially psychosocial issues, to talk it out more with the family, to guide them better, when to stop his futile every second or third day, we had a regular consultation with the patient and the doctor coming in. There was a nurse with him who used to do the dressings, and we used to direct her. And also we had, we had involved the wife and the children and other members of the family, as they were staying in a joint family. They were all very keen on taking care of the person. Availability of morphine was definitely an issue, but I don't know. There were people who offered help. There were vendors who actually came forward and gave this medicine to the patient. So that is about the story of this patient, and I have, have been having questions in my mind, and as you can see, I've divided those into two main headings: what has been done and what more could have been done. So the first part is definitely, do you think the management was satisfactory? Why do you think so, or why not you think so, and in what respect? Secondly, the patient stayed with us only for 15 days. And do you think that this time was enough for proper symptom and psychosocial management? Thirdly, why do you think the patient was in denial throughout the disease? And fourthly, we took the help of video consultations and telemedicines for his end-of-life care. What might be the ethical issues for this patient under such circumstances? Secondly, what more could have been done? The first question that came to my mind in this regard is that what and why would you have considered use of other modalities of treatment, for example, single fraction radiotherapy? I have asked this question because I and my team work very closely with the oncologist team, the cancer team, and it's definitely a multi-speciality approach. And the model that Dr. Punita has already shared definitely says that we need to integrate both palliative care and the curative part of treatment. So there are queries from radiotherapists and oncologists to inculcate few palliative intent radiotherapy or chemotherapy, even at the last stage. So would you actually consider using any of these modalities? I did not personally do that. Secondly, what could have helped the patient to accept the incurability of disease? This is perhaps the same part of the question, third question in the first part. And thirdly, do you think we could have negated the use of Ayurvedic medicine and told the patient and the family against its use, and especially when Ayush is a part of India's healthcare system now? So thank you very much for a patient hearing, and perhaps we can take this to a higher level of discussion. Thank you, sir.
Yeah, thank you, Sangamitra, for this presentation. I think just immediately after the lecture, highlighting so many issues, it really talks about the holistic nature of palliative care. And I could clearly identify the physical needs, the social needs, psychological as well as spiritual needs of this patient, and how as a palliative care physicians we can have a role to fulfill those. So are there any praising questions? People please talk, comments or questions. And Sangamitra, can we go to your last slide where there were two parts you had mentioned? So, are there any comments or questions from the participants?
Can you see my slide?
No, not really.
Can I make a comment?
Yeah, please, sir.
I think I would like to appreciate Dr. Sangamitra. She has done a wonderful work for this patient at this stage in all aspects. The presentation was very good. He included the psychosocial aspects, whatever she could. The two things that she was mentioning about was, one, should she have told about the Ayurvedic medications? I think yes, because as we all know, sometimes Ayurvedic medications also produce harm, like renal failure and other things which could accentuate the issues. So we should definitely inform, and it's not going to be help in any way. So there's no harm in being shying about it. You need to tell them, otherwise they won't know. Number one. Number two, the curative part. If a radiotherapist felt that palliative radiation for the exposed parts could help in reducing the bleeding or the pain. I mean, of course, the pain was controlled. Or maybe a palliative chemotherapy in a way that it doesn't harm the patient. But if it would help him clinically, it could have been attempted. But otherwise, I felt everything was done well and well proceeded. Thank you.
Thank you, sir. Anyone else from the faculty? Do you want to make any comments? Dr. Punita, Sunil, and are there any comments or questions really?
Yeah, so, I wanted to draw our
Dr. Punita, you are muted.
Oh, I'm so sorry. So I wanted to, draw your attention to the palliative care service domains that we had talked about earlier. So first and foremost, obviously, the most distressing part in listening to this case was the physical symptoms, pain, and pain. I mean, thank God for folks like Dr. Bora who were able to, provide relief to this patient as far as pain is concerned. My question, or my thought process as I was thinking through this was, the patient had a Ryle's tube. So I'm assuming that the morphine was being given through the Ryle's tube. This is, seems like, when you saw the patient, Dr. Bora, the patient was in the process of dying, right? 15 to 20 days.
He lived for another perhaps 2.5 months after I saw him.
Okay. So, was giving him the pain medication through the Ryle's tube, could you have considered an alternate route like IV? And again, obtaining medications like that at home is going to be a challenge. And I'm assuming that, fentanyl patches and all could not have been used in this case because of the the amount of weight loss that this individual may have had.
So
And
alternatively, yeah, sorry.
So the other thing could have been, I mean, in what I can say is in the United States, we are very fortunate to have, IV and sub-Q delivery of medicines and even rectal delivery of medications through catheters called as Macy catheters. So it's not like every time that you have to, put in a pill or something, into the rectum, but there are catheters that are available that can stay in place through which you can, which you can direct the medication and it's absorbed. So in fact, in the hospice that I work closely with, they are using, rectal catheters for delivery of medications for patients who are unable to take by mouth. So that's point number one. Number two that I wanted to raise was, having a Ryle's tube, what was the goal that we were trying to satisfy here? I mean, again, this patient was in the last stage of his malignancy. Not sure if, Ryle's tube was serving its purpose of providing nutrition, or who were we trying to really satisfy here? Or could the option have been, good mouth and good oral care and whatever comfort feed or whatever comfort, pleasure, taste that we could have offered to this patient? The other point that I was thinking through is, what about life therapeutic interventions? This gentleman wanted to be an actor. I mean, I've often come across situations where, patients with life-limiting or life-threatening serious illnesses, they had unfinished business. They wanted to do something very special for themselves. And once we got to know of that individual's dream, could we have done something for them in a special manner to make them feel like that they were an actor? Could we have done something as far as that was concerned? Then one more point that came across my mind for wound care is, the discharge from this wound must have been, I cannot even imagine how it must have been, with foul smelling and all of those things. A couple of interventions that we've tried here is, one is topical clindamycin, so helps with the anaerobic infections. And the second part is, just simple coffee beans in the room. They help with the absorption of the smell. Now, looking at the cultural aspects of care, his children, his wife, where were they in the, acceptance of the disease? could a family meeting between a palliative care specialist and his oncologist, and I understand that it was tough to kind of like, narrow down or pinpoint one of the oncologists, because this gentleman went through like, 3 different providers. So it was difficult to, hone in on one oncologist. But could that discussion where, you sat down as a family, involving his brother, involving his kids, if they wanted to be, involved, could that have helped? So just
Yeah.
some, thoughts.
Yeah, thanks a lot, Dr. Punita, for that review of this case from a different perspective and including many, many points which we probably could have thought of. I'm sure all the participants would look into these pointers, but sometimes, it's my personal opinion that even if Ryle's tube may not serve the purpose, we sometimes say that at that time we may be probably treating the relatives more than the patient. And in India, many a times they see that how can a patient die without eating or drinking anything. So it's kind of lifeline for relatives to have some access to the entry of food into a patient's stomach, really. So that could be, I don't know what others think, but sometimes we need to have a communication. I think for that, Sangamitra got very less time with the patient, considering the issues, really, what they had the challenges to handle. I think Anne wants to say something, please.
Yes, thank you. What a lovely presentation from Dr. Sangamitra. Thank you. And I think all of us are speechless because you did a marvelous job taking care of this man. I wanted to address question 2, which is about the denial of this young man that he was dying. I would like to offer the possibility that his coping mechanism was to stay in denial until the end, maybe to protect his family, maybe to protect himself. And while it may not be satisfying for us as palliative care physicians that we want him to accept his dying process, it may be that coping mechanism is what works the best for him. And at the end, we just need to say, this is the way it's supposed to be. So I just want to, I admire fully how you managed. I think this denial is not always, we joke that it's a river, denial is a river in Egypt that we must fight, but it's not. It can sometimes be the easiest way for somebody to cope. So just an alternative view for that. And I do think as the course continues, you may enjoy the methadone case series. Methadone may have been a way to help this man with his very complex pain, as you already alluded to. So thank you. And I also appreciate everybody's comments about the Riles tube and how it may have been treating the family's need to nurture with food. So always a struggle. But we also don't want to prolong suffering with needless interventions. So I think you handled this case brilliantly. Thank you.
Yes, thank you.
Thank you, ma'am. Just to add, perhaps I missed this in the beginning. We actually got the patient with the Riles tube. So I personally thought that this would be unethical on our part to remove the Riles tube at that point of time.
Wow. I mean, you truly, I mean, you got the patient at such an advanced stage of the illness where everything sort of like was nothing short of a disaster here.
Yeah, I
So
think Dr. Punita, but many a times still in India, it does happen like this, that when majority times patients are told that to take the patient home and there is nothing more can be done, that's the time we come into picture, and then we have less time to work with patient and family, and there is very less where very less time where we can work with them and make the whole process little more satisfactory to patients as well as family members. I think we are almost at 8:30. I'll just quickly summarize today's session in couple of sentences. Like, what was highlighted is palliative care is reducing suffering. Either we try to prevent it or to relieve it. We all have a responsibility as a citizen doctor to reduce this suffering. And non-abandonment, I think I like this word quite a lot, that we all should work towards non-abandonment in whatever capacity we can. I think the great difference between palliative care and hospice care, we all know the theory, but the intent change was something which I would take back from here, that because there is clearly a shift from other modalities of treatment which are trying to halt the disease, if not cure the disease too, there is no more curative option available. And I think there is a great learning here to consider death as a part of life or extension of life, not just death on one side and life on other side. I just want to say that I think probably all of us are doing not in actual sense telemedicine, but because we are very few and our patients are far and wide places, we have been doing at least telephone consultations, if not web consultations, for many years where the patient is in need. And as I agree with you, Dr. Punita, that uh, we really felt the need of these technology to help our patients during this COVID times. I think from Sir's lecture, I think we are at a significant place in development of palliative care as far as policy is concerned, undergraduate training is concerned. I think I must say here that there is some development is also happening where cancer treatment centers across India are being trained to deliver palliative care centers through Government of India, AIMS Delhi, and Asia Pacific Hospice Network. For last 3 years, this effort is being there, and we can see that now more and more cancer treatment centers are actually doing some palliative care. So I think our future of palliative care looks promising, and I'm sure all of us will contribute to the fullest. Sunil, if you want to say something as a closing remark, or
Thank you for the great discussion, and I would like to tell that we use metronidazole as a cover for anaerobic bacteria, and we don't have the catheter which you have mentioned. We haven't seen, but we use simple low cost technique like the butterfly set. We will cut the needle, and that will we will insert into the rectum, and we will be giving medications through that. So that's what we usually do.
okay, then back to you, Raj Lakshmi. We are closing.
Thank you all for that excellent interactive session. So we are launching a polls now for the feedback for the session. Please do it and then only leave the meeting. So we can see you next Saturday with a topic on pain management. Saturday, same time.